Welcome to Progenesis Academy webinar, session number 12. Today, we will be presenting 1-minute review on IVF lab practice during COVID-19. We have about 16 lab directors from across the country. We will be having each one present about 1.5 minutes presentation, covering most important aspects about the adjustment to COVID-19 that include PPE policy, sterilization, specimen handling, SOP changes, and COVID-19 screening and risk assessment. Riley, if you could maybe put on the slide, and then we can have all our participants start in the order that we have. Very good. So our speakers are on the panel right now, and let's start from the first one, which would be Chris and Ivani will be the first one to present, and then after that, we will get to the next one according to the list that you guys have. Kristen, the floor is yours.
Okay, the timer starts. So when Nabil first asked, I thought either this is crazy or it's a great idea, because you get all these people together and we all want to know what each other's doing. So it's great. It's sort of like speed dating with the motley crew that you got on the screen here. So I combined a couple of these points together because I thought it was a little bit difficult to do in 3 slides. So I'll just buzz through real quick. So for us, for specimen handling and PPE, as always, I think all of us do, we treat all samples as potentially infectious in the IVF lab. We process all of our sperm samples in the hood. We're fortunate enough that we have hoods in the lab as well as one in the OR. And so as with the advent of COVID-19, we moved out of the OR and are not doing retrievals in the OR. We actually did start today because we just had too many. Staff are wearing N95 masks in the OR. We have always poured follicular fluid into the specimen cup at the end of the retrieval, so we're not dropping dishes into the biohazard trash. So we put them into the cup, cap the cup, and then throw the cup away. We are doing cryo storage as usual with no quarantine at the current time. And then taking a little extra time cleaning between procedures and cleaning at the end of the day, and remembering the kind of obscure things like the lids to the incubators and the eyepieces on the microscope, etc. The next slide. So with regard to changes to SOP, you know, really important that we stay updated with our local, state, and CDC guidelines. Patients are screened with a phone call the day before their appointment, and they are screened via questionnaire as well as a temperature check when they arrive at the office. Staff are self-screening via questionnaire. All staff and patients are wearing masks at all times. They're not allowed in the office without a mask. The physicians are still, even what is 2-3 months later, quite engaged with telemedicine rather than having a lot of patients in the office. We have a very limited number of patients in the waiting room. In fact, your automobile has become your new waiting room. Social distancing in the lab as best we can. We are fortunate that we have a lot of space so people can spread out. We encourage home collection of specimens whenever that's possible. No partners or families, dogs, parents are allowed to accompany patients into the office. We also cut down on any deliveries into the lab area. That would include couriers for PGT. We come out to them rather than have them walk through the office. So it gave us an opportunity to really look at how we do things and made a number of changes that we probably should have made anyway. Next slide. So in terms of risk assessment, I'm sure there are others who will talk more about risk assessment with regard to the sperm and eggs and embryos. I'm going to talk just a little bit about for us, because I think that our risk is greater with patient to staff, staff to patient, staff to staff contact, rather than risk from the embryos or the gametes. I really feel that communication, coordination, and cooperation is really, really important, that the lab, the clinical team, the physicians need to be on the same page. They need to be understanding and respecting each other. We also need to understand and respect the needs of our staff. People have unique situations at home that we need to respect if they need to be at home, if they need additional PPE, if they have specific concerns. We're fortunate in that the lab in most clinics is geographically isolated from the rest of the clinics, so we don't have a lot of exposure. And in our lab, we have little patient interaction. Even in labs who have a lot of patient interaction, there's opportunities to minimize that. As I said earlier, we treat all samples as infectious. Your HVAC system is a great opportunity to make some improvements to protect us as well. At this point, we haven't had any COVID detected in follicular fluid that I know of. And so we still treat it as potentially infectious. And I know all of you know the now famous slogan of dilution is the solution to cut down risk to the embryos. Diluting many times over every time we use something. And that's it for me. Was that 1.5 minutes?
Way over.
Thank you so much. Thank you. Ali, you're next.
You unmuted?
I think you are muted, Ali.
Or I've tried to use my...
We can hear you now.
You're on.
Hello, everyone. For us, we do a little bit differently. So I'm going to talk about the lab and clinic because we work side by side each other. So for the lab, what we implemented is to wear surgical masks everywhere we do all the times. And also we added to the social distancing rules as much as is possible. We do measure temperature of hours and lab people upon arrival. And if there's a fever, if they're home, we discourage them to come to work. If they're at work, we won't let them to go to the lab so that we refer them to the physician to the next action. We also wipe all surfaces, like, everything being touched, like microscope knob, incubator door, handles, doorknobs. Twice a day we do, once in the morning, once in the afternoon, and chairs. Next, please. So in regards to specimen handling, we don't do anything differently. We do the same as before. We always wear gloves for the semen and follicular fluid. However, unlike many other new labs and like many other old labs, we use isolate. So that means we are not exposing ourselves to the samples. So even retrieval is being done under the isolate. So we are pretty contained all, samples. Next, please. For major part, we are doing it from the patient point of view. Before the patient starts the cycle, we test them for coronavirus. And I understand that this is important also how the sample is collected. So we do not send a kit to the patients to collect themselves. We refer them to our institution at USC so that they do collect the sample by professional. And usually we do have a result on the same day. This test being done before cycle start. So during cycles, partner is not coming with the patients. And patients wear surgical masks all the time while they are in clinic. And staff take the temperature and there's a questionnaire they sign and they fill up and sign. If there is fever or cough or combinations, we send them for another testing. If it's positive, then we cancel the cycle. We already indicated to them in the consent form that if they are positive anytime during cycle, then cycle will be canceled. We only have one patient at a time in the waiting room, and one behind the door and one in the car, so that not interaction between patient. And everything that's being touched by the patient also will be wiped up right away. Thank you very much.
Thank you so much, Ali. Mark, you're next.
Okay. Get that one, obviously, everyone knows. Next. Okay. Yeah, similarly for us, we are continuing with standard precautions for specimen handling. In terms of SOP changes to response to COVID, for semen analysis and wash dry UI preps, we actually are a little different. We are still in the position of strongly encouraging home collection if the patients live within 45 minutes of the hospital. Greater than that, then we do require them to collect on site. In terms of our operating rooms, patient and pre-op and post-op rooms, semen collection rooms, we use Ecolab Oxicide as our cleaning agent. Seems to work fairly well. It's mostly hydrogen peroxide and acetic acid. But the andrology lab and the IVF lab, we're just using hydrogen peroxide. And similarly, we do everything under isolettes and lamellar flow hoods in all working areas, and those are cleaned after each use. And of course, obviously very important, hand hygiene, using soap and water and hand sanitizer. And we do require the patients, when they walk into the hospital, to use hand sanitizer and are given a glove, or given a mask rather. Next. For screening, all of our egg retrieval and frozen embryo transfer patients, we require COVID-19 RNA testing, and it has to be done within 72 hours of the procedure. So the hospital has a mixture of things. They have a COVID-19 ID Now test, which has a very fast 1-hour turnaround time. We don't use those very often because the next thing that's available is a test that we send out, which has about a 24-hour turnaround time. The antibody screening is not accepted by the hospital at all. Similarly, for risk assessment, only the patient is allowed in. We do allow a single visitor for the egg retrievals. Obviously, the partner needs to come in because they need to collect. But still, for our frozen embryo transfers, the partner waits outside in the car, and then immediately post the transfer. The patient is walked outside, and then they can leave. Similarly, all staff have temperature checks upon entering the hospital and are given a hospital mask to wear, and it must be worn at all times. I think the only exceptions are, when you're eating, things like that, or in your private office. If a patient has a positive COVID test, or anyone around them, they will be canceled. Next slide. Oh, that's not my slide. Okay. I guess, okay. Yeah, I covered all that, so that's us for us.
Very good. Thank you so much, Mark. Sheila, you can start now.
Okay, perfect. We have very similar policies that were discussed just a moment ago. And also, Mark Dow's lab is across town from us. So it's also worth noting here that some of the policies and procedures are also affected depending on if your lab is part of an organization like a hospital or university system versus a private practice. So we're a private practice, and so we were able to enforce some of the policies based on the recommendations that are set forth. So our PPE policy requires our staff to wear masks at all times while in the building. Gloves are required for all lab staff while handling specimens. And then we try our best to maintain the social distancing that is recommended for the 6 feet. It's not always possible, obviously, but we certainly are fortunate that we do have a large lab, so that way we can go ahead and space out as best as possible. N95 masks are encouraged for physicians and anesthesiologists while working with the patient under anesthesia, because obviously that can pose higher risks of transmission in the event that the patient is positive. For patients, we are requiring that they wear masks. We are not providing masks for them due to PPE limitations and availability. We do ask that patients bring their own masks. Cloth masks are acceptable. And we also ask that they follow the 6-foot social distancing rule. We are limiting patients in the waiting area, and so that way we don't have too many patients at one time. Disposable gowns or bunny suits are required whenever partners are going into the OR with the patients. So that way we try our best to keep our environment as safe as possible. Sterilization, so obviously we are doing what many other centers are doing. We're going ahead and asking our staff to sterilize all contact surfaces daily, multiple times a day, whenever possible, whenever they have a break. So at least 2 to 3 times a day with bactericidal and virucidal wipes. And so of course these are not IVF surfaces, just common areas. Hand washing is required upon entry and exit of the lab area. That's mandatory for all staff. And the admin area is wiped down very frequently. So as soon as they sit down, as soon as they get up to leave, they'll wipe down. Lab surfaces in the IVF lab, we use 70% alcohol and water at the end of the day, but throughout the day, we're using peroxide and water between patient sample checks. As far as patients, we don't necessarily have enforced sterilization procedures per patient physically. Next slide, please. Specimen handling, we're observing universal precautions. We had a empty liquid nitrogen tank. So because we had that, we didn't specially order an empty tank. We went ahead and started to store patients in this tank for now until we have future updates as far as any adverse effect on pregnancy. So then once we learn more information with literature, we can make updates as needed. We do limit to 1 appointment per time slot on the schedule for IVF and in our andrology lab. So before we used to double book, now double booking is prohibited. So just that way we're limiting patients in our waiting area. We do have a limit, so we've decreased our volume to 10 IVF sim starts per week and a max of 5 FETs per day. So that way we can space out our patients and are not exposing our staff to too many patients at a time. Patients, we have mandatory offsite semen collection. So we have enforced this unless the patient lives more than 45 minutes from the office. So that way it minimizes the number of patients in our small collection rooms. As far as SOP changes, we do have extra stock of liquid nitrogen tanks that we have ordered as far as like refill tanks, and additional consumable supplies are stocked in the lab just to prevent us from being in a place where we're short. For patients, we did enforce COVID-19 antibody testing. And so if IgM is positive, we will absolutely cancel the cycle, and the patients know that going into it. We've updated all of our, or most of our consents to then incorporate electronic signature options. So that way the patients are not coming into the center for witnessing or notary. We are currently accepting e-notarized documents, which before we weren't doing that. I didn't even realize that that was an option. And we're also looking into alternate e-sign verification options for our consents in-house. Patients do wait in the car, like most other centers had, most other directors just mentioned. And then we call them in once we're ready to see them. Next slide, please. So COVID-19 screening for staff, we will provide IgG, IgM, and IgA antibody testing if staff is symptomatic, but otherwise we're not providing any screening. But further down, I'll tell you what we're doing as far as self-assessment. Patients, we are screening all patients for FETs and IVF starts with antibody screening. And we opted to do that versus the RNA test because we didn't want to expose our staff, which will be sampling through nasopharyngeal swabs, to possibly get exposed in the event that the patient is pregnant. COVID-19 risk assessment. So for staff, daily temperature check logs and self-monitoring is enforced. And we ask that if they feel any different as far as fever or flu-like symptoms, that they'll go ahead and report and stay home. Vendors, temp checks we'll do temp checks on vendors just the same as we would for patients, and we're doing a COVID questionnaire. So that'll go over any recent travel, or any possible exposure to an individual who might be positive with COVID. Patients, same thing, questionnaire at check-in. And then also we have all patients signing a risks acknowledgement waiver, which is now required for all therapeutic treatments. So that way they understand that going into treatment poses risks that are unknown at the current time. And so that just helps with the liability for the clinic. And that's my part.
Thank you so much, Sheila. Kevin, you may start now.
Okay. Okay, next slide. Good afternoon, everyone. I believe most of the fertility centers have the similar policy to run the lab under the COVID, the pandemic. So we are already consider all the specimens are infected. So we always wear gloves, masks, and then use the clean hood. So we didn't really need to change the SOP. However, I prepared the PPT plan based on the information from CDC, ASLM, and then SLBT guideline and the recommendation. Certainly, like I centers, we measure body temperature on arrival of all STEM members and the patient, and the log any symptoms. Of course, if anyone showed a little higher temperature, like a 99 or 99.5, the STEM members or patient should return home and then take a necessary test. We are using mask all the time while we are working. Patients also should wear the mask all the time while they are staying with us. Next slide, please. As everyone knows, wash hands is one of the most important ways to prevent or spreading infection. This is separate from wearing the mask and then gloves all the time. In addition to the wash hands we more often clean all the surfaces of the work table, clean hood with hydrogen peroxide. We even clean the door handles. And the semen production room, after each patient use them, we clean the room very thorough. Next slide, please. In terms of COVID testing, we have a lot of international patients. So we'll definitely run the test if the patient or any of our STEM members show any relevant symptoms. So far, luckily, no patient showed any symptoms. Thank you.
Thank you so much. David, you may start now. I think you are muted.
Okay, here we go. All right. Okay. We were totally shut down for the entire period of 7 weeks, and all staff were tested in mid-April with the nasopharyngeal RNA test. So after that, all patients were tested at baseline starting in late April, and IVF patients tested again 3 to 4 days prior to egg retrieval. And during this period, when we started the stimulations, we started doing semen analysis. We hadn't done any semen analysis up to this point. So we started doing semen analysis again in preparation for the IVF patients. We started retrievals on May 12th. FET and IUI patients were tested once at the beginning of their cycles. Patients are tested prior to their procedures. And all staff and patients must take their temperatures daily prior to starting work or treatment. And an employee patient with a temperature above 101 must go home. Okay, next slide. Okay, sterilization, specimen handling. All embryology surfaces are disinfected with OSAfe immediately following use for retrievals, ICSI, biopsy, or after any spills. We like OSAfe because of the the volatile organics that you don't have with OSAfe that you would have with other with alcohol peroxide. So we only use OSAfe in the IVF lab. All surfaces are disinfected at the end of the day after the biohazard trash has been removed. Hydrogen peroxide is used in the andrology lab and in the clinic. These areas are not on the embryology lab air system. All semen specimens are drop-offs. We do not allow any collections on site. For men who have to transport further than 45 minutes, we give them 5 mLs of sperm washing media and instructions for use as a transport solution. So we either give it to their spouse and they take it home, put it in the refrigerator, and because we have people that from as far away as 2 hours to come up for procedures or semen analysis. So we have done this, and this has worked really well. Egg retrievals are limited per week. We do 5 to 8 retrievals per week. We don't do up times now. We did have up times. Now we have retrievals certain weeks and FETs certain weeks. And we do no more than 4 FETs a day. Next slide. All staff patients must wear mask. Egg retrieval personnel wear N95 mask and face shields. The andrology personnel wear masks and they work behind one of these sort of a small plexiglass barrier. And our lab in Raleigh is not really big, so the embryology staff is limited during the day. We have 1 to 2 people in the lab at a time with distancing. So the person that's doing the egg retrievals will be in there by themselves. And then the next person will come in and do hyaluronidase. Somebody else will come in and do biopsies, ICSI, thaws. And all of our staff meetings with the clinical staff are done through Teams. We have not had any staff meetings yet since we started about a month ago. And we have, of course, we had lots of Teams meetings during the shutdown, but we still are doing that even though we're all on site. And that's all I have.
Thank you so much, David. Now we're going to go to Bill. Bill does not have, Bill, are you going to present a PowerPoint or just oral presentation?
I'm just gonna talk.
Perfect. All right, the floor is yours.
Okay, sounds great. I'm just gonna give you some differences. Everyone's pretty similar. Our entire staff, whether you work in the lab or not, change at the clinic. So you go from your street clothes, so to speak, to scrubs every day. Take your temperature, and of course, if you're not feeling well, any signs of anything, you go right to management to discuss what to do next. Any patients fill out a 4-question questionnaire on arrival. There's a 3-part station as they walk in the door. 1 is to sanitize their hands. 2 is to put a mask on if they don't have one with them. And the 3rd one is to fill out the questionnaire. Then they are directed either to the surgery center if they're having a procedure or upstairs if they're being monitored. We have reduced the days that we monitor, or the number of times we monitor patients. Also the times that we do pregnancy tests also. They essentially do a pregnancy test at home. If it's positive, then they come in no matter what, but their first pregnancy test is at home. They come in for 1 visit with us, and then 1 ultrasound before they're released to their OBGYNs, where in the past they lasted through their first trimester with us. On the lab side of things, we just, again, we take our temperature, we do our usual stuff because we change into scrubs every day like we have. The only thing is wiping down the retrieval area with between patients. Usual. We still use our biohazard as we have been. So there's multiple patients in the biohazard bucket. We wipe down the lab essentially once a day at the end of the day with OSAFE. The only other things that there's not much difference there. We do test the patients. The patients are tested, like Mark said, I think it was Mark, close to their retrieval. So kind of their first, we only see them at baseline and day 10. And then we either trigger then or we blind trigger patients. There's very few that we have back after that. We used to be, there was no downtime for us. We have changed that. We work in a batch right now. We'll probably do it through the summer. Batches are limited to 30 retrievals a week. Our FETs are not batched, but we do cut down on FETs during TVA weeks and kind of ramp them up on non-TVA weeks. Even though we have a 30 patient cutoff, we actually double batched last week. We had 70. So that put a bit of big strain on the lab. So hopefully we don't see that again, but they promised we won't. And that's really it. So I'll give it to the next person.
Thank you so much. Thanks, Bill. Klaus? I think your mic may be muted.
That's not my lecture.
It's actually Dr. Bayhan's turn.
Okay, so let's go with Zaki. We had a last minute change, and I think that's what happens. Zaki, can you go now, and then I'll take Klaus after you.
Am I able to unmute myself? Do you hear me?
Yeah.
Okay, good. All right, let me go through the slides very quickly. I mean, we're gonna cover pretty much similar ideas, basically. Here in Fertility and IVF Center in Miami, we cease our operations about 8 weeks or so. And recently we decided to go back into business. So just before doing that, we just physicians, laboratory personnel, and everybody in the lab just come together and develop a assessment for the risks and possible mitigation strategies. And I'm not going to focus on the clinical side, but overall, we just basically implemented social distancing and screening through questionnaires and temperature checks. Implemented a no visitor policy unless absolutely necessary for the procedures to go on. And throughout the clinic, we have face mask is policies for everybody, patients and staff alike. As far as screening concerned, we are just implementing a screening procedure for only retrieval cases. If the patients are coming into a fresh cycle, then they've been screened twice before, one before the stimulation, start of stimulation, one before the egg retrieval. FET patient does not go through the same process because the risk associated with the anesthesia is not as great as the retrieval cases. That's why this is our screening. In terms of screening, that's what we do basically. As far as staff concerned, we haven't implemented a mandatory screening, but we also allow anybody, any staff member, to take the test if they need it. And some of us has done it, and some of them just basically waive that option. Next slide, please. As far as PPE usage and decontamination, what we are doing is basically what we do normally, the universal precautions, but on steroids, I could say. The underlying, if I wanted to underline a couple of things, is going to be everybody's wearing masks in the lab right now. That was not the case before this, but right now everybody's using those. Of course, I mean, those glove usage, face mask and shields are available, and scrubs are mandatory right now. I mean, these were a little lax before this, but right now we are just pretty stringent with all of these. Decontamination-wise, we pretty much follow a similar methodology, and every surface is being decontaminated by non-alcohol-based wipes, basically, and between each procedure, between each usage of the equipment. But we are mainly focusing on, in terms of protection of the laboratory personnel, we are mainly focusing on creating a social distancing in the lab. Of course, I mean, our lab structure just allows implementation of some of these. It's not going to be available everywhere, of course. If for instance, if there are more than one, if there are more than one embryologist is using the lab, and we try to separate out the stations for the day and then clean those clean those equipment in between procedures. And lately, we are just minimizing our access to any clinical area where the patients are just processed. I mean, when the clinical personnel who are getting in touch with the patients are always wearing their N95 mask, and they are taking extra precautions, but we are just trying to minimize our contact with the patients as much as possible, basically. Next slide. Well, when it comes to specimen handling, again, we are just following the universal precautions, a little more stringent, a little more careful, and everything is slightly exaggerated. In terms of, I mean, because of the screening and testing strategy we are implementing, we don't want to see any COVID-19 positive patient in the streamline, and fortunately we haven't got any so far. And in that sense, we are not expecting those samples ending up in the lab. But in any case, if we are talking about oocyte donors, they are going through that patient screening strategy. They've been tested. Because we don't handle sperm donors, we are not just basically dealing with those as well. In terms of sexually intimate partners, we are just following current protocols, meaning we are not basically testing specifically for the COVID-19, other than typical screening procedures. But if I mean, in any case, these are contingencies. It never happened, and we don't want to see those happening. But if any of those positive cases are gonna end up in the laboratory, we have we have special tanks for those, and we're gonna quarantine those. But other than that, any of the other cases, which if they are not indicated by our screening and testing, they are just basically stored usually according to our protocols. In terms of our SOP changes, I mean, we developed a single SOP addressing the safety issues. That because it is a very comprehensive and addresses the specific areas in the lab and in the clinic. If there are major changes in the procedures, we just integrate it into our current routine protocols as well. And I believe some of the changes we introduce is going to stick around even after the COVID is not become a major issue. At that point, these are going to be our part of our regular SOPs for good, I believe. And that's all I have now. Thank you very much.
Thanks, Zaki. Klaus, you may start now.
Thanks. First of all, thanks everybody for letting me be a part of this. It was really awesome to see so many near and dear friends on this panel. Thanks again. Next slide. So here's basically what we were doing. I did what Christine did, is I've kind of combined a few things here. So hang on just a second. So one of the things that we're doing is all patients must wear personal protection when they enter the clinic. We're using the parking lot and cars to hold patients in so we can stagger blood draws and ultrasounds. We do temperature checks on all staff and patients when they come in. Something that we've always done, but I thought it was good to emphasize, is that all staff change into fresh scrubs at work. That including also changing into masks, shoe covers, and gloves when appropriate. We basically only wear gloves when we're doing egg retrievals and when we're processing semen samples. We don't wear gloves when we're doing embryo changeovers or, you know, working with embryos. We do daily assessment of all patients. Our anesthesiologists have requested that all of our patients had COVID testing 3 to 4 days prior to egg retrievals. Fortunately, we have a company called Atlas Genetics that is coming to our clinic and actually is testing all the patients here, or the patients can go down there. We only are testing the male patients if they're having a surgical sperm aspiration. And rooms are being cleaned a little bit extra now between patient visits. The procedure room undergoes a really deep, thorough cleaning at the end of each day with just a normal cleaning between each case. Next slide. So as far as like getting closer to us, our biggest fear right now is mostly in andrology and anything having to do with sperm. So we're doing extra cleaning of the collection room. Just like others, if we will allow patients to collect off-site as long as they live within, 45 minutes. The exception for that are severe oligospermic guys who have really bad sperm samples. We're having them produce on site. We haven't really changed how we're sterilizing equipment. That would be like, say, speculums and things like that. Nothing like that's really changed. One thing that we have changed in the lab as SOPs goes is now the centrifuge is cleaned between every sample, and all the andrologists are venting the semen, the centrifuge samples underneath a biological safety hood. Oocytes are treated the same as always. Dilution is a solution. One thing we do is just make sure we remove all the extracumulus cells. The only change that we've really made, like I said, is we're extra cleaning the centrifuge at present, and that's only because we have an extra tank, and it's probably overkill, is that all frozen samples are being kept in a separate tank until we get some idea what's going to happen. But I personally think that might be a little bit overkill. Thanks very much.
Thanks, Klaus. Now we have Ben, if you can start now.
Yes, thank you. As for our PPE policy, we're following ASRM recommendations, and I kind of give a snapshot here of update number 5 that was just released this week. We follow those when it comes to procedures. We do require all patients and employees to wear masks while they're at work, on top of the procedure of wearing a mask for procedures. As for sterilization, we're continuing our current policy of using quaternary ammonium compounds like Olosafe for the embryology surfaces. And we do have our own concentrate that we use for floors and walls. Also hydrogen peroxide. In the andrology areas and the clinical areas, we're using the bactericidal and virucidal wipes, but the quaternary ammonium and hydrogen peroxide for the IVF suite and also for the procedure rooms. This is kind of question out for everyone is, a lot of other industries are starting to use vaporized hydrogen peroxide to sterilize areas. We've looked into it, to potentially for the high traffic areas. It's not something we've done. I'm just kind of throwing that out there, wondering if anyone else has considered that, or those in the hospital setting, whether they do have access to something like that and whether they use it frequently. Next slide. For specimen handling, we just treat everything as infectious. We continue to use universal precautions. No, we're using our PPE, we're doing all the andrology work and sterile type 2 hoods. We collect our follicular fluid in a cup and dispose of it at the end of a retrieval. Originally, we were separating embryos into a separate tank at the beginning of the pandemic, but as we've gained more information, more knowledge, we have discontinued that practice and no longer separate embryos or semen that are being frozen at this time. As for SOP changes in response to COVID-19, we're trying to space out our procedures a little better, just give us ample time to clean the room between patients. We try to minimize face-to-face patient interaction. Try to ensure social distancing between patients and staff as much as possible. We're trying to use our semen collection rooms, I guess, more efficiently. We're alternating them just to give ample time to clean them between patients. Okay, next slide. As for COVID-19 screening, we are requiring all of our patients prior to STIM to be tested, and then again prior to retrieval following ASRM guidelines. And those for our patients undergoing stimulation for retrievals. And it's extended to any patient who's going to require anesthesia. We require them to be screened for COVID-19. The state of Utah has a Healthy Together app that we require all of our employees and all of our patients to use. It does have contact tracing abilities, and so all employees and patients are to either email us the response to indicate that they used it that day or to show us a screenshot. And then we also take temperatures as employees and staff are coming in. For the risk assessment, we try to physically separate our critical staff and our physicians. We try to minimize their contact together, or they're not in the office together at the same time. Same for our embryology staff. We try to form teams the best we can to try to minimize the risk of them being exposed at the same time. We limited patient volumes. We're trying to not ramp up too quickly, but to be able to allow for social distancing. So we have minimal staffing on hand to ensure social distancing. And also, as other people have said, we've only allowed patients in the clinic. The patients check in from the parking lot, and then we let them in and try it while the patients are in the clinic. We try to minimize their contact with surfaces as we escort them through the clinic. Thank you.
Thanks, Ben. Christian, I think you're next.
Hi, everybody. Thank you so much for the invitation. I would like to, first of all, tell you about Argentina. Argentina is a country in South America that we have 45 million people, and almost 24,000 people are infected with COVID-19, and 32% of them are recovered, and we have a 2.9% of dead people. And I will also want to say that the 88% of the people that are infected are in Buenos Aires. I mean, for example, in my state, in the northern Argentina, we have more than 1 million people, and only 46 people are positive with COVID-19. It means that most of the people that are infected are centrally in the capital of the country. Next. Regarding the PPE and risk assessment and testing policy, I would like to say that patients, for routine visit, they have to use the face mask. Every time they come to the clinic, they have to fill the triage with a questionnaire, and they have to use the PPE for all the IVF procedures. We have a waiting room with limited capacity and the social distancing, 2 meters or 6 feet, and we only allow just the patient to come in. There is a restriction for access for all the partners, and they have to wait in the car outside of the clinic. We also have a limited number of patients per day. For example, actually, we only allow 2 or 3 IVF procedures per day. And we check the temperature for all the people that come into the clinic. In Argentina, considering the guidelines of the Argentine Society of Reproductive Medicine, at this day, we only are allowed to do IVF cycle in patients with low or poor ovarian reserve, advanced maternal age, and oncological patients. Testing in general depends on the geographical location. As I said you before, almost the 90% of the positive cases are in Buenos Aires. So we have to test, we have to perform first a triage and a questionnaire before the ovum pickup. If it's positive, the triage, we have to test with IgG or IgM. And if it's positive, we have to postpone the procedure. Also, Samara says that we have to exclude patients with the COVID-19 PCR test positive. In the case of oocyte donors, ideally we have to do a PCR test, but it depends on the geographical location and the amount of positive cases. In the case of the IVF lab, we have to measure the temperature and do the triage daily. And the testing depends on each IVF center, and I said you before, the geographical location and the amount of positive cases. We have to sign a code of conduct in order to avoid unnecessary exposure. And the PPE that we are using caps, gloves, gowns, surgical masks, goggles, and the face shield. Also, we are using the biosafety cabinet class 2 in order to work with the sperm samples mainly. We use clean scrubs daily, and the embryologists must be separated in 2 different teams in order to not overlapping between them. And we have to clean between patients and procedures and do a deep cleaning at the end of the day. Next, please. Regarding the specimen handling about the semen, we are requesting to make the collection at home in a sterile container. Inside the lab, we are doing an external decontamination of the container, and we are processing the samples in a class 2 cabinet individually. The centrifugation, we are doing a density gradient and an extra wash. We have to take care about the centrifugation. We have to clean all the surfaces and the centrifuge between samples. Regarding the ovarian and testicular tissue, we are processing that tissues under the biosafety cabinet. And for the follicular fluid, we are doing in a workstation that has to be cleaned before and after every case. We have to handle and discard the follicular fluid with extra care and use the vertical flow cabinets. And also we are doing an extra wash dish. And for oocyte and embryos, we are doing the denudation in order to remove most of the cumulus cells and using also an extra dish for washing. In all the cases, we are cleaning and sanitizing the surfaces and the equipment with oxygen peroxide 6% and use an adequate use of the waste disposal and sharp containers. Also, we are, regarding the SOPs, we are mainly doing an extra cleaning, an extra care, mainly with the native follicular fluid and the sperm. We are doing a lot of dilutions. Regarding the cryopreservation, we are keeping the samples in a separate tank. And we also increase the stock of PPE and materials because, as you know, most of the things come from the United States or other countries. So we have to be sure to get all the enough material to continue working. Regarding the sterilization procedures, we don't have any changes. Thank you.
Thanks, Christian. We are running a little bit late on this presentation, so if you guys can keep it around 1.5 minutes, that would be appreciated. Marlene, this is your turn. Thank you so much.
Thank you. I'm going to talk about 2 of my 5 labs, one extreme to the other, the sort of on the left-hand side, literally San Francisco, the right-hand side, Albuquerque. Next slide, please. So in all of both my labs, everyone uses PPE, staff and patients both. No one comes in without a mask. No one stays without a mask. There's more hand washing by everyone prior to entering embryology. But in Albuquerque, they have a very high turnover, very high flow rate in their air handling system. So they wash before they come in, but they don't use masks actually in the lab. but in San Francisco, labs all the time with everyone, limited contact with patients if possible, but the patients are required to wear a mask also. Next slide, please. Sterilization, the San Francisco lab shut down, and then when we restarted, everything was cleaned. All the labs were cleaned with hydrogen peroxide. Everything that everyone touches for the day is wiped off, obviously, like others have said, but that includes pipetters, strippers, pens, etc. No major change in specimen handling any of the places, except more cleaning of the centrifuges. We're still doing biopsies, cryos, warmings as usual. However, in San Francisco, what they really have done is reduce the number of patients per day. The San Francisco lab handles 2 different groups of patients from 2 different groups of providers. So each group alternates days and no more than 2 retrievals per day. Next slide, please. COVID screening is the most restrictive in San Francisco. All staff has to have a negative COVID test before they can come back to work. For patients, we do a COVID, the PCR testing for them at suppression check and on day 7 of their stims. Same thing, they have to have 2 negative tests before they start an FET. Symptoms are reviewed with patients at every phone call. Symptoms are reviewed with patients at every visit. Temps are taken with every visit. For staff also, all staff have to take temps, and they have to fill out a COVID survey online with the city of San Francisco and have a copy of it sent to the office every day before coming into work. There are limited numbers of patients. We're doing the same thing everyone else has talked about. Next slide, please. So they all sit in their cars. I'll do the next slide. Oh, and that was me. There we go. I bet I was less than the minute and a half.
Excellent. Excellent. Thank you, Marlene. Thank you so much. Debbie, the floor is yours. And if you can check your mic.
Sorry. I'm going to focus on the things that are different because a lot of them are a little bit redundant. So yes, we use masks at all times. We do wear eye protection at egg retrieval and sperm prep, although the microscope and eye protection we have a few issues with. Sterilization, we do use hydrogen peroxide. I did notice a couple of people said 3%, or one person said 3%, others said 6%. So we use 6%, and I'm curious to find out, I think 6% is the minimum amount to actually be vericidal. So I'm curious to see if 3% is acceptable by others. We do a more thorough cleaning between procedures in addition to hand washing before coming into and leaving the lab each time. We also do no on-site collection. Next slide, please. So the one thing I did see that we did do differently is we did completely restructure our emergency plan for a pandemic. Our emergency plan for pandemic used to be one line for a viral outbreak, which basically said, get away from wherever the viral outbreak is. But it obviously didn't address a pandemic. So we completely restructured our emergency plan to discuss splitting of the staff, working from home when possible. We did hold a staff meeting and train everyone in our office on liquid nitrogen safety and being able to fill and monitor tanks. We are a smaller laboratory, sometimes with only 2 to 3 embryologists on staff at any given time. And we were a little concerned, gosh, if we were both to get sick, who's going to take care of the tanks? So we trained everybody in our office on being able to monitor and fill liquid nitrogen tanks as an emergency backup plan. We did create a consent waiver for patients. So that was something new. Of course, the questionnaire, and we do screen all of our patients before egg retrieval, before FETs, about 3 days before. And we did do staff antibody screening, but we're not sure how accurate that actually was. Okay, I'm done.
Thanks, Debbie. Thank you so much.
I tried to get in 1 minute.
Very good. BK?
Thanks, Nabil.
Thank you.
So here in Center for Reproductive Medicine in Orlando, Florida, we pretty much do all the precautions. We take all the precautions, and our policies are very similar to what they other speakers have just described. We perform the same kind of, we take same precautions such as physical distance. We don't bring more than one patient at a time in the recovery, in the waiting area. And patients are, male partners are not allowed to come or asked not to come accompany the wives here at this time for when they're coming for providing a sample. They are asked to bring the sample from home if possible, exactly like other speakers just described. And if they have to come and provide a sample, they are given a time when there's less crowd or less number of patients here in the clinic. They have to wait in the car. They are sent a message on their phone when they can come and come for providing the sample. Everybody has to wear a face mask, just like it was mentioned earlier, and frequent cleaning of all the surfaces, doorknobs, and every furniture, everything is cleaned and wiped a couple of times a day, morning and afternoon, after lunch. There are notices in the elevator and all the lobbies and everywhere, waiting areas for people to avoid touching their face, nose, mouth, in order to not get infection on their face. And the next one. Next slide, please. So specimen handling policy is nothing different. We had always followed the same precautions. Just like Christine mentioned earlier, in order to avoid any kind of contamination or any kind of exposure to the follicular fluid or blood, they started putting it into a cup and dispose of. We had always been doing that, so we have continued to do that. Not change any of the specimen collection or handling policies as far as semen is concerned, and or oocyte or retrieval. And laboratory staff is always covered their faces with mask and always gloves, wearing gloves for any procedure. So our policies remain the same. As far as vitrification of the eggs, embryos, or sperm cryopreservation is concerned, we did not change any policies in that regard. We are not using any different tanks to isolate these samples at this time. And continuing as per our current old policies. Next. So currently we are lucky in the sense we are in a geographical location where the infection rate is relatively low as compared to some other areas. Even in Florida, down south, Miami and Fort Lauderdale, in that area, they have reported a higher infection rate. We are about 2.5% positive infections in Orlando area or in neighboring counties. I hope it pretty much drops down from here further for us. And currently all patients who undergo procedure, any kind of elective procedure, are being tested by RT-PCR. And in case of IVF patients, the screening is done on day 4 or 5 of stimulation, and the results are available within 48 hours to us. So prior to retrieval, the policy is, in case for some reason, if we are unable to screen a patient prior to retrieval, all OR staff and physicians, they will have to wear double gloves and N95 masks, and will have to take extra precaution. As far as lab is concerned, we will be handed over the follicular fluid tubes here by the OR staff. So we do not have to do anything different other than our regular universal precautions. So currently we were staggering the lab staff also until a few days ago, but now the increased volume has made it impossible for us. So we have pretty much full staff, but we have got a large area in the lab. So we are trying to keep distance between the embryologists. Every embryologist has a separate hood and they work in their own hood, clean it, and that way we are trying to keep it separated. I guess that's it for me.
Thank you so much, VK. Thank you. Tony, you can start now.
Thank you, Nabil. Let's go to the next slide. I'm going to just talk about some of the things that we do different. Just like everybody, we have standard PPE. We treat everything as it's potentially infectious. The only thing we have really changed is that we are a lot like a lot of people are doing. We've added the hydrogen peroxide and for cleaning during the day. I'm an alcohol guy, so I didn't like using alcohol in the lab between cases. As we were shutting down, it was really easy to run two teams. I think Debbie was the only person that kind of mentioned this. And as we started back up, I wanted to start off with two teams. We're doing the drop-off CMEs. We do curbside. Basically, we go out to the parking lot and pick the samples up from the guys. I really thought it was a great idea, adding the media that David suggested. Right now, we're not doing any testing as people come in. We're actually trying to, we just got a new Roche machine where we can offer antibody testing. We're actually working on getting that set up. Let's go to the next slide. As I was saying, some of the challenges we had as we were slowing down, it was easy to maintain two teams. Starting back up, I wanted to do the two teams, but we've gotten so busy. Only about 2 weeks into it, and we started all our FETs, biopsies, and transfers. I had to bring the teams together, and that brought up the challenge of trying to keep the distance from each other, because we're all wearing masks, and it's a small space we're in. We don't have a limited number of people in the lab. We just work as we do, whatever needs to be done, we do it, but wiping things down and being safe while we're doing it. Now I was saying we added the peroxide. One of the things, it mentioned sterilization. We don't do, everything is disposable, but the sanitization, we have, the hand sanitizers all throughout the building, and we do check people as they're coming into the building every day as they're coming in. And one last thing we're doing, we're actually consenting our patients to treatment and consenting them for pregnancy. That's some things we're doing. And one of the things the docs have really enjoyed not having is we've usually had both partners there during the OB ultrasounds, and apparently to limit the foot traffic, they're only having the female there, the wife there, and doing a FaceTime type of a scenario where the husband is sitting in the car. So unfortunately, I guess it's limiting the foot traffic in the building, and is actually makes things go a lot smoother. And that's it for me.
Thank you so much, Tony. Kim, you can start now. I think your mic may be muted.
Okay, I got it, I think.
Perfect.
We're a little bit different. Realize everything that we work with is going to be used in someone else, because we're an egg bank. So there's a lot of changes, and there was a lot of thinking that we had to do prior to opening up again. We shut down for about the last 7 weeks of no cases to reduce COVID exposure and to get a little bit more information about COVID. So a lot of what we do is very similar, but here's an outlook from when you're dealing with donor tissue. One thing that I think has been very important that we do, and that is we store all of our blood from all of our donors so that we can do future RNA tests or antibody tests should we need to. We also make sure that any eggs that have a cracked Zona Pellucida, they're excluded from being vitrified, but we had always done that in the past too. We also like hydrogen peroxide around the lab. I've never liked alcohol in any of my laboratories, So we've always used hydrogen peroxide. And to answer a question, the CDC has recommended 3% hydrogen peroxide for 6 to 8 minutes. And I think it's mainly because that's been shown to kill rhinoviruses, and rhinoviruses are more difficult to destroy than coronaviruses. Next slide. So we wear PPEs. Everyone has their own office. So if you're in the clinic, everything that happens to anyone coming in that office is the same, whether you're a patient or whether a worker. You get a questionnaire, you get temperature check, and we also add O2 sat reading on everyone. And then PPEs are worn whenever you're not in your own office. When you're in your own office, you can take off your PPE if you want. And we do no gathering in public. We only have one person working in a hood at a time, and we only allow 2 people in the laboratory at a time, maintaining social distancing. Next one. So here's what we do for the COVID screening that I've already mentioned. We do have additional COVID-19 questions for the donors. These are ones that you probably saw that were ideas put out by the FDA. Currently, the FDA has no requirements for anything related to COVID-19. We don't do any RNA testing or antibodies for COVID. And that's it.
Thank you so much, Kim. Thank you. Thanks everybody for the presentation. We just got the results from the poll. Miriam, are you able to read the poll for us, or do you want me to read it?
Yeah, I'm able to view it.
Okay, very good.
So the first question was, is it required for you to wear masks at all times while at work? And 18% of participants said yes, required in the lab only. 81% said yes, required anywhere on site. And then 1% said no, not required to wear masks. The second poll question was, have your IVF staff been tested for COVID-19? 59%, or the majority, said no, the staff hasn't been tested. 22% said yes with antibody, 16% RNA tested, and then 3% have been tested with RNA and antibody. And then the third question was, are you storing gametes in separate tank during COVID-19? 81% said no, 19% said yes. The fourth poll question was, at what stage will you be testing your IVF patients? 38% said prior to egg retrieval. 35% said prior to stimulation. 24% said will not be tested. 20% said prior to embryo transfer. 18% said prior to their first visit. And then 16% said all of the above. And the fifth one was, if your clinic is tested for testing for COVID-19, how many patients has your clinic tested? 49% over 50, 12% 51 to 100, 3% 100 to 250, and 35% said that they're not currently testing. And then the last question was, if tested, how many were reported to be COVID positive? 53% said 0, which is the majority of the participants, and 35% have not tested, 11% 1 to 5 tested positive, and then 1% had 6 to 10. And that concludes our poll.
Thank you so much. I would like to get your feedback. One of the panelists, if you can give us some feedback on the poll. One of the questions that I really see interesting is the question about cryopreservation and having a reserved, tank just for the new cases. Klaus, can you give us your opinion on that? What you guys are doing?
Well, we're storing them in an extra tank because we happen to have a tank. We had just added several cryo tanks around February. So we're putting the samples in there, but I'll be honest with you, I think it's a little bit overkill. We're doing it more out of the abundance of caution. Hopefully ASRM will make some kind of statement about it. And then at that point, everything is just going to get put back together. But frankly, I think it's a little overkill. We're doing it just because we have the space.
Okay. Do we have anyone on the panel that has a different opinion, opposite? Yeah, go ahead, Kim.
Well, I don't know if it's the opposite. I kind of lean towards Klaus. Just that I don't think that it's necessary at this point. It's not been shown to be sexually transmitted. For all the data that we have, it doesn't appear that it's going to be able to infect embryos or eggs. So I don't think that's very necessary. And my main reasoning is we have these other viruses around us all the time. We have seasonal influenza, for example, that's around us all the time. We don't do it for that. We don't do it even though we have other diseases like rabies or Rocky Mountain spotted fever, all these other viral caused diseases. So that would be my reasoning.
Very good. One more question. Is conventional IVF pose any additional risk compared to ICSI when it comes to contamination, COVID-19 contamination? And I'll take anyone who is willing to answer beside Kim and Klaus. Tony? I think you're muted.
Yeah, you know, I wouldn't treat them any differently. It goes along the lines of there's no indication that it's sexually transmitted. And so, and I know that some of the washing methods through gradients or even through the Zymote is filtering out anything from the seminal fluids that could possibly have it there. So I would say it's minimal risk, if any at all.
Any other opinion?
I certainly agree with that. We don't have enough information in the literature. Not enough has been published or brought to attention. There was a study that came out as a pilot study or preliminary data out of China that did report men having positive COVID testing in seminal fluid. But as far as their transmittability into embryos and risk assessment for pregnancy and to the fetus, it's just unknown at this point. And I agree with Tony that it's minimal at best.
And IUI would be the same you know, explanation or the same. Mark, what do you think?
Yeah, I agree. You know, as we said many times, dilution is the solution, and I think we follow that. There's plenty of data, you know, done on HIV positive males using that sperm for IUIs and stuff, and not getting their partners positive for HIV when using washed IUIs. So I agree.
Very good. So when we look at the evidence, any evidence that we currently have on, you know, sperm expressing some markers for COVID-19 or potential infection or contamination of sperm sample, what do we have currently? How can someone in the panel give us an assessment of the literature as of today, where we are?
Just like Sheila mentioned just now, the Chinese study where I think 34 or 38 patients were tested and 9, I believe, had RT-PCR positive indications in the sperm. But there was another study from China prior to that showed no contamination or not contamination, no evidence of any COVID RNA in the sperm or in semen of infected patients. Am I right? I mean,
Kim, you had
anybody else seen that one?
Yeah, I think Kim raised your hand. What is your take on this?
Yeah, I think BK's expressed it correctly. The first study that came out of China, we have to remember that that was done on men that were at least 30 days out from being symptomatic. The newer study that showed that there were RNA sequences from the virus in men's semen, 24% were positive, and those were basically from men that were symptomatic at the time. So that might be the difference.
Thank you so much.
Most, I think we're going to see, if it is a sexually transmittable disease, and which I don't think we really know yet. I think it could very well be like HIV, where you can have seropositive men that aren't shedding virus in the semen. You can have men who are seronegative that have had HIV in the past, and they can still be, you can see occasional semen analyses or ejaculates that do have HIV in it. So at this point, I feel like I don't know. I don't think we have any good, clear evidence on any of this.
Christian, you can.
Yeah, sure. I also want to say that maybe we have to wait for a little more evidence about that. Right now, there are at least 4 trials that are conducting around the world. And those trials are trying to follow the patients in after 1 more, 2 months, or also 1 year later after be positive for COVID-19. So I believe that our patients will be those kind of patients, nor the patients that are in the acute phase. So we have to wait for more evidence about that.
Very good. Any other opinion in the panel? Kevin?
Yeah, I had lots of kind of experience of handling the HIV infected the person. So what I did is at least we have to use the 3 layers of the sperm gradient solution to handle the semen sample. And also the little more we have to be careful to remove the top layers. So after washing twice, or maybe sometimes even 3 times after spinning the samples, and then we didn't, and also tracking more than 200 of the pregnant cases, and then we didn't discover any transferred, the HIV transferred cases to the 2nd generation. So at this moment, since we don't have any useful evidences, so that we should highly recommend the patient to use ICSI protocol instead of using the insemination. And yeah, Kim, do you have any the addings or something?
Yeah, I was just going to say, I know that there are some groups, I think Mike Reed in Albuquerque is using the Pro Insert device from Nitacon, which is device that is developed especially for purifying semen, where you don't have to go through those layers and where you can remove bacteria and a lot of viruses. It hasn't been proven, I don't think, clinically, but I think, you know, if I was processing semen, I'd be using it on all my men right now, especially if these were cases where the woman definitely was not symptomatic, which almost all the women we see aren't.
Very good.
Okay. Yeah, but most of coronavirus, most of our patients are asymptomatic, and then we actually don't know. Unless we tested them, we actually don't know if they are infected or not. And also a couple of days ago, in China, in the collaboration study between China and then the US, and then they studied 11 dead persons, the testicle, and then they examined, and then they didn't find any coronavirus infected the inside of the testicle, but actually they found a lot of kind of deformed sperm and then everything in the testicle. So still we need to collect and then experience a lot of the research on the coronavirus, how much they could affect on the organs. Thank you.
Very good. Thank you so much. One more question, and this is for Ben. You mentioned an app for tracing. How does the app benefits your IVF patients?
Oh yeah, so within the app, they're allowed to use GPS tracking to track your movements across the state. And so the app will notify you if you've come in contact with someone who's tested positive for COVID-19, or you've been to a location where someone's tested positive for it. And so it gives the patients a little more reassurance knowing that they haven't been potentially exposed to it. But our staff are also using the same app to also track their movements and whatnot, just to hopefully minimize the risk of someone coming in that's asymptomatic and may not know that they've been exposed.
Very good.
What's the app called?
It's just Healthy Utah app.
You may want to share it on the screen for people to see.
I had it on one of my the screenshot. It's the Healthy Utah app, but I'd assume it'd work for in Utah. I don't know about other states. I mean, one of the presenters mentioned San Francisco has an app for people to use there. So I'm assuming state by state there might be different apps available.
Yeah. I have a question
For
about.
Works though. I'm sorry, for these apps to work though. I mean, it is critical that how many people many people are using those, so you're gonna get an accurate or reliable information. I mean, what type of data are used on those apps and are they really reliable in terms of your those tracing and making a reasonable assessment out of those?
No, I totally agree. That it's all boils down to whether people self-report or appropriately or not. And so we also have them fill out a questionnaire when they're coming in, just on their symptoms. But yeah, no, definitely it's no good if no one uses it appropriately.
Very good. I have a question regarding, are you guys participating in Aspire clinical trial? There is a clinical trial going on right now, assessing the impacts on pregnancy, impacts of COVID-19 on pregnancy. Do we have any participants in that study, any clinic in this panel?
We are. We just started, so in the early stages.
Can you tell us a little bit about the program? Maybe others in this panel will be interested.
Actually, no, because I just got an email yesterday. So if anybody else has more experience with it, I welcome you.
I have spoken to the investigators, the principal investigators in that program. We actually invited them in the last webinar, and I have a little bit of contact with her. Basically, the trial is they're doing antibody testing, collecting serum for all the patients that are starting IVF treatment or they are naturally conceiving, and they are following every other week with antibody testing. They're using just the rapid test, and they are looking at the first trimester to see if there are any effects on the placenta or anywhere else. Okay, very good. So one more question. Do we have anything left that we have not seen in the presentation of all the 16? Because I'm gonna move next to one paper that is in publication that Kim is working on. I would like him to talk about it, but maybe we can start with you, David. Do you see any added recommendation in terms of treating samples with potentially contaminated with COVID-19?
Yeah, I mean, I think like any other infectious sample, we have to treat. We treat every sample as it is infectious, and if it is totally infectious for COVID-19, I think we should. I would rather store that off-site if we have embryos, and we're doing biopsy on almost everybody. So we would, of course, practice universal precautions, doing everything else we're doing in the lab. But I think if we know they're COVID-19, I think we would probably store them off-site.
Very good.
The embryos.
Thank you so much. Debbie, do we have anything else to add in addition of all the presentation that we have seen today?
Yes, me. No, I think we've covered it pretty well. I think most labs are agreeing on a large portion of what we should be doing. I think we all might have learned a thing or two to add, and I think it was good.
I just am curious, are any lab directors here on the panel accepting patients to cycle through who test positive for COVID?
No.
No.
Okay.
No.
Well, we have had a case of a clinic that had a potential surrogate that was positive in IgG, and they're trying to do a little bit more tests on RNA to see if they can clear that patient to be a candidate for surrogacy. So that's the first case we have had for a positive antibody test. And I know that you guys mentioned that you have some positives. Can someone give us a little bit of a, input of how you guys dealt with those cases of positive patients? Anyone in the panel that can tell us about that?
We had 2 positive patients coming in for their FETs, and we canceled them without thinking twice, just because FETs, of course, aren't that nearly expensive as an egg retrieval and things like that. But yeah, our policy, the hospital stands by us as well, that any positives are canceled. If you do have a positive COVID test, again, this is an RNA test, you need to have 2 negative tests before you're even allowed in the hospital, with the exception, obviously, of the ER or something like that, where they have isolation rooms.
Very good, very good. Let's look at the poll results. I think we are approaching the end of the webinar. I have one more question for Ali. Ali, do you have anything, any observation or feedback on what you have heard today as far as how the clinics are? I mean, we've seen a lot of clinics that are doing pretty much the same thing. What do you have any take on that? Anything that has not been covered or you would like to add? I think your mic is muted.
I think everybody covered lots of stuff. So maybe we are not on the same page, but overall mainstream, we are agreed that, we are do the precaution, wear a mask, and although some they are using quarantine tank, but it's not really necessary. So
very good. We have the Kim, go ahead. I think you're muted.
I just really think that we need to think about 3 things mainly here. Number 1, we're really concerned about infections between healthcare workers and patients. That's our main concern right now. But we need to be thinking about, what about the embryos that we are vitrifying now? We are safeguarding those. We don't know whether the antibodies are going to afford adequate protection to patients in the future. And if not, if those embryos do have virus on them, they may reinfect a patient or infect a person more in the future. And the third thing we need to think about is donors, of course, because that's the other group that we have to that we need to make sure we don't infect in the future. When we think about those 3 things, one thing that no one's brought up that I think is important, and that is the protection of the Zona pellucida. It's been shown that it is one of the main protections of the embryos from viruses. Klaus probably knows this research. It's out of the cattle industry, but all the studies that have been done showing that if you contaminate cow embryos with a virus, they don't get passed on, have all been done in Zona intact embryos. We don't know what's going to happen with zonas that aren't intact. When you do biopsies, you may be opening up a can of worms for a future infection.
Very good. You mentioned that you were working on a paper, you submitted a paper, that requested paper on precautions that can be taken, kind of summarizing all the precautions that can be taken during COVID-19. Can you give us a minute summary of what that paper is? And maybe Riley, you can post the title of the paper so we can see a little bit. Okay.
So this was a paper that was requested by JARG, and I am working on it with Dr. Mitch Shiwi. We've already finished it. We've turned it in, but we have listed in there some practices that we think we should consider in our everyday working in this day of COVID. One of them I mentioned is the Pro Insert device by Nidacon for preparing specimens. You know, if this is a highly infectious disease as it is, right now, if the sperm is going back into someone that they're sexually intimate with, this may not be as important. But if you are storing frozen sperm, this may be very important, and I think needs to be used for all frozen sperm today. The other thing is we don't know whether there are viral receptors on the cumulus cells or on the Zona pellucida. So it's very important, we feel, to consider complete removal of cumulus cells. And I think the other things that I want people to consider, when we get more information on the virus, I think we'll be able to know which one of these we should do, but possibly doing your transfers earlier so that you don't have a breached Zona pellucida. You don't want to go ahead and especially vitrify embryos that have hatched or are hatching. We need to rinse quite a bit and make sure that we're doing a lot of rinsing. We may want to vitrify earlier. We may want to isolate all those embryos that have breached Zona pellucidas so we know which straws they're in, which ones have been biopsied. And then, as some have considered, maybe even have a quarantine tank for some of those, although as most of the embryologists here have mentioned, I think the possibility of having cross-contamination is very, very low. And that's kind of my summary there.
Very good. Thank you so much. You know, this is really a great discussion, and you know, we are lucky to have the entire panel here of experts. It's hard to get the opinion of everyone because of the time limitation. Marlene, I think you haven't spoken much, and I wanted to give you an opportunity to give us your thoughts on the webinar and maybe the points that are missing, if any.
Well, I think the biggest thing I'm concerned about long-term and in terms of just specifically even just the next year is how much we don't know. I just think there's so much more to find out that it can be very complicated and difficult, because I think if the second point Kim made there is almost, you know, if we're not going to biopsy, we're going to go freeze before vitrify, before we biopsy. These are big steps back, you know, like we're going back 10 years compared to what most of us are doing now. You know, I have one program that's 100% ICSI, 100% biopsy. Going back to not doing that is going to be a tough sell. It's going to be a tough sell to the physicians. It's going to be a tough sell to the patients. Some of these things, and I hate to make steps. I hate to take big steps that are not scientifically based. So it's a concern.
Very good. Thank you so much. Any other opinion? Yes, Kevin?
Okay, I actually have a question for you. Almost every day I'm seeing the articles worrying about false positive and then negative of the COVID testing. So since you are running the test, can you explain us a little about the specificity and then accuracy of the antibody and then antigen test?
Yeah.
And then my another question is, what if our patient is confirmed case? Just one test is enough to stop the procedure, or do you recommend the second testing as a confirmation? That was two my questions. Thank you.
Yeah. So regarding the studies, if you scan the literature, you're gonna see on the RT-PCR test, you're gonna see an accuracy going from 60 to 90, high 90s%, right? And so it's hard to trust any of that literature because there is so much diversity in accuracy. The issue with COVID-19 is that all these hospitals that have cases try to publish, and they're not necessarily following scientific, you know, criteria on how they collect the data and how they run the tests. And so you have all kind of publication going, being available out there with all these you know, different numbers. So the literature, if you see it, is somewhere between 60 and 96 or 97%. If you look at the studies where they have looked at, for example, correlation between CT scan, so they scan the chest to find traces of COVID-19, and real-time PCR, the correlation is in the 90%, so 92 or more. That's, I believe, if you run a correct test with all the markers needed. In this case, you have to target at least 3 regions of the virus to have an accurate representation of the RNA. If you do that and you're collecting, your collection method is correct and precisions are correct, you should expect somewhere in the 90% as far as sensitivity. The majority of those tests are good when it comes to false positive, but the false negatives, they are not that good. So you may get a negative and then a week later, that same patient will come positive. My recommendation is, if you test someone, if you're doing going through an IVF cycle and you test someone at the very beginning of the cycle and then they are negative, it doesn't really mean that they are 100% negative. You may have a false negative result there. You have to continue testing. If you test twice, the likelihood of having a false negative for the same patient, it's very low because you're narrowing that false negative by testing twice. That would be my take on the RNA test. As far as antibody tests, you have 2 types. You have the rapid test, which we have seen in the market is about 30% sensitivity. And then you have the ELISA test that is approximately 92% or higher. And I think if you avoid rapid tests in antibody and you do more than 1 test in RNA, if you do both, you are more likely to have better data, basically. That's my opinion about testing. I would like to take any comments before we wrap up the meeting. Do we have any other opinion in the panel? Very good, Klaus.
Yeah, I think I came from an animal background, and we froze thousands and thousands of cattle embryos and transferred them all over the world. And one of the things that we were really hard and fast on was trying to reduce any cracks in the zona and things like that. So I would really question about using ICSI all the time, because we know that ICSI creates a hole in the zona pellucida. And I can tell you, in the animal science industry, if you have holes in the zona pellucida, you cannot freeze those embryos because the potential of viral transmission is great. And in fact, in pig embryos from the Agricultural Research Council up in Canada have found that blue tongue virus with alarming frequency inside of pig zonas when they crack the zonas and then put the embryos into culture media. So dilution is the solution. But if you have a crack in the zona, at least with porcine virus models, that it's very hard to dilute that virus out. So I would ask everybody to rethink about doing as much ICSI as we're currently doing. That's it. Thanks.
Thank you so much. Any other opinion before we wrap up the meeting?
I had a comment. I really appreciate everybody's thoughts and input. I think we're all learning. We need to all keep up with the literature, all keep up with what the guidelines are. But just as a panelist, this was really great for me to hear what all these people are doing. And I think we all learned something from each other. I appreciate that. Thank you.
Thank you so much. We have taken a poll from the audience asking them if the webinar has clarified some of the questions that they had. 87% said yes, 13% said somewhat. That's definitely as a result of the clarity that you guys have and the experience and knowledge. I thank all of you for bringing your inputs. We asked them if they would like to see a webinar like this, and 100% said yes. That's like a record on feedback. I really appreciate the feedback there. With this, we are coming to the end of the webinar. I'd like to thank all of you for participating and for bringing your experience and knowledge. Next week on Wednesday, 3 p.m. Pacific time, we're gonna have another webinar. This time will be geared towards patients, and we will have some physicians and maybe one of the lab directors that didn't have a chance to attend today. Thank you so much. Thank you for your inputs, and I will see you next week. Thanks a lot.
Thank you for putting it together.
Thank you.
Thanks, everybody.
Thanks,
Bye,
everybody. Bye.
Bye.
Thank you, everyone.
Thank you so much. Bye-bye.